Mark Sendak, who you've already heard from, is going to moderate this session, and he's going to have everyone, I think, introduce themselves. And Mark is the Population Health and Data Science Lead at, how are y'all saying it? DHI? I think that's what you're saying. Okay. And he helps lead the interdisciplinary teams of data scientists. Apparently, I'm losing my voice today. I didn't know that was going to happen. But I'm going to turn it over to him to lead this panel. And I think all our panelists, if you want to turn on your cameras, and we're going to just let you go for it. And we're excited. Thank you.
So I am absolutely thrilled. I see everyone's videos on. I do want to give folks an opportunity to introduce themselves. For the audience here, this is an incredible group of people who I've had the privilege to work with over the last almost 2 years now. And I've learned so much from them, and I'm excited to be for them to be able to share their expertise with you all. So Suresh, I know you answered questions, but also introduce yourself, and then I'll just call people in the order that I see them. So Suresh, you first.
Good afternoon, everyone, or good morning, everyone, depending on the time. Good morning. Yes, it's still morning. Good morning, everyone. Thank you for the opportunity to be here. I'm Suresh Palu. I'm the director for Duke Institute for Health Innovation, and I also serve in the School of Medicine as Associate Dean for Innovation and Partnerships.
Steve.
Good morning, Steve Meff. I'm the CEO at PCCI, the Parkland Center for Clinical Innovation. And it is such a pleasure to not only be part of the conference, but Mark, thanks for including me in this panel.
David.
Hi, everybody. David Vital. I'm at Mayo Clinic, and I'm the Vice Chair for Software as a Medical Device Regulation, and lead a team at Mayo Clinic to help enable our other Mayo Clinic innovators across departments to build safe, effective, and ethical AI.
Alexandra.
Hi, everyone. I'm Alexandra Valladares, and I'm a community representative working with the Health AI Partnership in this wonderful collaboration. And I'm also a Board of Education member, currently serving in the district, this local district that I live in Durham County. And I'm also a Board of Trustees with the North Carolina Central University, one of the historically Black colleges and universities here in the area. And so I'm super glad to be here. Thank you for having me.
Kia.
Hi, everybody. My name is Kia Shaw. I'm a lawyer at DLA Piper. I specialize in digital health, so supporting all of our clients and to get their products safely to market. And I'm really privileged to be on the leadership team of the Health AI Partnership. Looking forward to the discussion.
And Deb.
Hi, I'm Deb. I'm a researcher at UC Berkeley, focused on evaluation and auditing deployed machine learning systems. And yeah, super happy to have learned from this group for such a long time. Yeah.
So we have a lot to get through. Most of my questions are going to be addressed to the full panel. There's going to be a few that I ask specific individuals. I'll try to keep an eye on time, but really excited to jump in. So the first section of questions that I prepared for everyone today is just to help set the stage. We're here talking about AI at a time, like Alethea mentioned, 1.5 years ago, ChatGPT burst on the scene, and now everybody knows AI. Everyone's talking about how it's going to transform every industry. But I want you to take a second for healthcare specifically. Take a step back. Why is AI an important innovation in healthcare? And why should we be prioritizing it despite the noise we hear elsewhere? David.
All right, you saw me moving. We could take this in a lot of different directions, but I'll just start with a really basic one, which is the burden on our healthcare system, and in particular the physicians who their primary responsibility is to take care of patients. And as we've seen technology increase in healthcare over the last decades, we've kind of seen the same level of burden and rigor applied onto the physicians. For example, like the emergence of an electronic health record, a lot of physicians found themselves turning their time and effort away from patient-directed tasks to computer-directed tasks, right? Entering notes and typing and so forth. So where I see AI coming into play is to actually reverse that trend a little bit, to start taking tasks away from the technology and allow the physicians the time and capacity to go back to focusing on the patients. And that can be through semi-automation, automation, flagging things that would otherwise be tedious tasks that those physicians would take on. And so I think it's really, really important that we start seeing a reversal in that trend of more technology means more work for physicians and turn it into more technology means more time for patients.
Mark, I'll follow up Davis because my train of thought actually builds a little bit on what he said. I think where the AI can play such a critical role in healthcare is to help make sense and manage through just the vast amount of data and information that we're asking our physicians to synthesize by the minute, by the hour. Good example of that from our end is we've built the last couple of years have deployed a trauma mortality model. And, you know, take Parkland, one of the busiest emergency departments in the country, asking physicians and clinicians to actually manage the amount of data that it's being collected real time on patients that show up with trauma. Is just a monumental task that it's so much based on experience. It's based on the many other factors that they're dealing with real time. So having an AI model that's able to be validated, tested, to be able to bring together all that information as comes real time, synthesize it, create predictions, interpret it, and then use it to enhance the decision making that those individuals are being asked to do. Huge impact on communication across teams. There are critical decision points where the trauma surgeons, they are trying to decide with the OR staff and the ICU staff when a patient's actually ready for surgery. So the communication across those teams is facilitated by this. Communication during shifts, right? Think about the amount of information that needs to be translated when a shift occurs. Again, how do you actually synthesize all of that and help enhance the decisions that those individuals make? That's where, to me, AI has such a huge opportunity to actually make and enhance the care that physicians are already providing.
And Keo and Deb, I know that the two of you look at AI in many different industries. What do you feel like is particular about healthcare where AI is important?
For me,
go ahead.
Go ahead,
Keo.
go ahead, Deb. We're both so eager.
I'm sorry if my camera, I think I'm like buffering a bit. But I was gonna mention, because I also do audits of AI deployments in other domains. I think something that's really interesting about healthcare is just how aligned the users are to the impacted population in this domain. So for example, in the criminal justice space or with hiring, the user of the AI model is separate from the patients, the teachers are separate from the students, and the impacted population is sort of separate from the user base of these models in many cases. And I find that in healthcare, partially because of the history of the regulatory environment, partially because of a lot of the history of patient advocacy, and also, the underlying principles of that professional user. There is a lot of alignment between sort of these professional users, those that are making use of the technology, and then those that are impacted by the technology. And there's a lot of sort of infrastructure to enable communication between these two. And, you don't have users that are sort of operating against the best wishes of the patients. Ideally, like the whole system is structured so that the health practitioners that are making use of these systems and the vendors that are sort of, designing and building for those users, also really think about that impacted population of patients and really keep them top of mind. So I feel like the healthcare domain is one in which that does happen. And that's definitely not something to be taken for granted. It doesn't always, that alignment of sort of priority in terms of the well-being of the impacted population of patients in this case doesn't always happen in other domains. So I think that's something that's really unique about healthcare. I think something else that because I'm more, I guess I'm typically more on the critical side of these systems. So it's interesting to think about, you know, why we should think about AI and what's interesting, unique about it. I think something that's been a very compelling use case for me to observe has been in lower resource communities. A lot of these systems sort of operate as kind of, you know, crowdsourced opinion for, you know, various aspects of the clinical decision-making process. And definitely in environments where, you know, there's not a lot of access to information or to a second opinion or third opinion or 50th opinion, it becomes a very critical sort of resource. So very excited to sort of see how AI systems sort of increase the robustness of decision making in these contexts and allow for people in lower resource domains to access sort of a broader set of opinions about various aspects of their decision making.
And Kio, I know you were going to say something.
I'll be quick and just add on that I think why I see such vast opportunities for AI in this particular sector is because of its complexity and also because of the traditionally long timelines, right? If we think about this as from drug development to actually getting to treat somebody. So if we just take this idea that AI can help to speed up and optimize, then the opportunity is massive here when we have, you know, maybe a decade's lead time on getting to treatment. And that's before we've even gotten into something like personalized medicine, because right now we're treating everybody with a one-size-fits-all regime. So I think it's just that we have such a complex system with so many players and such long lead time that we can really improve it so much. And these technologies can fit into so many different aspects of that system. And I think that's why it's such a game changer in this particular sector.
Yeah.
I'm going to comment slightly differently on that particular piece. The piece I'm going to integrate and at the same time say certain aspects of it where I think things are going to head. So I view AI as a revolution in healthcare, right? It is a revolution, number one. The primary thing is its potential for the ability to really democratize access to high quality care. It has the potential. We need to realize that. That's number one. The other important piece is it has the potential to empower patients and providers. That's one. And I think Kio mentioned it as well, certainly a potential for personalized care like never ever seen before, right? That's the piece that we should be able to attain with AI, right? So that's certainly possible. The other important piece is by democratization of healthcare, high quality care, it is going to be applicable even in resource limited settings. That's the important piece. You can actually extend early detection to resource limited settings, and you can provide the right level of treatment as well, regardless of location and socioeconomic status. I think those things are absolutely possible with AI. From the empowerment side, I would say patients have the ability to get to information. If we have the right chatbots, which are trustworthy, then we can get the right information to the patient's hands so that they can actually be much more engaged in their own health. And same thing with provider side as well. Steve mentioned it. It's about reduction of burden. Can we really provide the right information at the right time to the right set of clinicians so that you can actually reduce the overall burden and improve the actual outcomes and certainly improve the relationship between the providers and the patients? I think these are all possible with AI. The bottom line is the success depends on ethical implementation and a good amount of human oversight. I think that's what's really required.
And we're definitely going to dig into the challenges, but I think, Suresh, it's helpful to kind of set what we see as the potential opportunity. So before we get into the next section of questions, I do want to take a moment. So Alexandra, you have been the community representative on the Leadership Council team. I already saw someone post in the chat, excited to see that there is someone with your perspective. So I want to give you the stage. What have you found surprising about the way that health systems and the folks on this panel are trying to, how they're thinking about AI and trying to put AI into use.
Yes, and I first want to apologize because I'm literally there's some background noise. I hope that you can all hear me well. Can you hear me?
Yep.
Pretty well. Awesome. Yeah, this has been meaningful work for me to interact with professionals in this area, to bring some of the insights that I have in terms of working as a community organizer, particularly grassroots community organizer, and especially a lot of the learnings during the COVID pandemic and some of the ways that healthcare organizations are trying to work with community organizers, and some of these inroads, especially now with Mark having had that trajectory of pitching in during that time and also approaching this work of artificial intelligence in healthcare settings. I mean, it's been very a really wonderful opportunity. I think one of the things that I continue to reflect on are some of the conversations that I have with folks around my involvement in this project. Folks have asked me, like, how does AI really change things when bias is so embedded in everything? It's embedded in systems. There's such injustice, historical injustice. There are such gaps, whether any system you think about, education, criminal justice, and especially the healthcare system. There are so many stories of, inequities and even generational inequities that continue to be at the forefront of why certain people not only lack access to healthcare, but also mistrust it, even when they do get access to healthcare. And so being a part of this wonderful team, I have deep respect for all of the folks that have come to know from this team. And what I have offered in terms of, even as I review frameworks, there was a particular case study. There were two case studies that were in the HEAL framework. But I'm gonna talk about one particularly, and it was the one about postpartum depression in women who this is one of those topics that is not talked about as much, but it's actually near and dear to me because I've been working with a lot of families over the years with migrant farm workers, a lot of the challenges in terms of access, a lot of moms who are looking for childcare options anywhere, and most of them are private. Sometimes there are public opportunities. And when you think about the level of kids who have immunizations on time, and also mothers who are getting that care, that follow-up visit, right? That is something that is, an inequity when you have a lot of moms go through, labor, and then after that, the follow-up visits are not happening, and they're not happening sometimes because of barriers to access to care, but also, again, I bring in the mistrust, that is also a factor. And so in the conversation we had, hearing from different providers, especially New York Presbyterian, was actually bringing that to us and having a robust conversation. There were so many things that were uplifted in that space about how AI, particularly AI, can do predictive modeling, can kind of even if there's a screener, right, that can be given, and the times of screeners can vary. I know that screeners have the time that screeners are offered to patients changes, especially for autism, for example. Like there have been examples of screeners being provided earlier as early as 12 months old, for children. But for moms who are going through maternity, some of these screeners at the follow-up visits offer an opportunity to talk about symptoms and talk about maybe if they, anything that can diagnose them for postpartum depression. And what I saw in terms of AI was an opportunity to take into account contextual information, demographics, geography, all these different layers, all these different clusters. And I think that piece, I think the actual, maybe Mark can help me, but it's like there's I think it's the conversations around how we not only approach access to care, but also like use predictive modeling to look at symptoms that may not be present right now, but because of the contextual relationships, because of the socioeconomic factors, the social drivers, we can actually, have models that say this person may be at high risk for postpartum depression, for example. And in this case, is the accuracy going to be the main priority? Maybe not. Maybe there might be ways that the accuracy may be 90, maybe not 100%. But I think that the fact that there's insight and the fact that there's, when it comes to models that can offer the highest possible like benefit to communities, I think that those are things that we need to consider. And so I just wanted to share that there, I can go endless on different examples that I've seen, not just in postpartum depression, but also when it comes to H. pylori, like families who have, navigated all kinds of antibiotics, overuse of antibiotics for different things. And it come to find out, I've had quite a few families who are like, it was H. pylori all along and nobody knew, the doctor didn't know. And so I could go endless, but thank you so much for this space and this time to share.
Thank you, Alexandra. And Steve, I do want to make sure that we get to an opportunity for you to talk a little bit about all the work that PCCI has done with social determinants and incorporating that into data and models. So, okay, we're going to go into the next section, which we're going to try to dig into some of the challenges. And I think, Alexandra, you set this up nicely, because the first question that I prepared is about how we separate when we think about a model versus a solution to a problem. And clearly, when we talk about kind of postpartum depression, it's not like there's a technology that I can have on my computer and push a button that will then go solve access to postpartum depression. So let's zoom out from that specific use case, and what can people offer in terms of how should we be thinking about AI solutions, and what is the role of a model in the solution?
Mark, I guess I'll jump in. And you teed it up really nicely. The model itself, it's actually a small part of the solution, and I think one of the misconceptions often is that AI is about the model, and that's certainly the sexy part. But when you actually look where you spend the most amount of time, it really, is not the model. I would say probably 40% you spend it on the data exploration, the data normalization, ingestion, mapping, cleansing, merging data sets, all that work that needs to happen. And then, the other bulk of time, you actually spend it at the back end with the education, the workflow integration, the change management aspect of it, and the ongoing model updates, the evaluation, the retraining, and the support. This is a quick example. We've been building a workforce violence predictive model. And one of the first things we did a hackathon. Well, we spent literally 6 months on the data, exploration, normalization, all those things. And then the hackathon was 2 days, and a series of teams were able to build some really robust models over the period of time. I think sort of just a good example of how a solution, not only building it and deploying it, but then the ongoing support monitoring needs to be in place end to end for it to make sense.
Yeah, I'll also add from like a sort of computer science perspective, people overly focus on the model and predictive accuracy. And so I think a lot of people are becoming surprised that, that's not enough, which is something that I think anyone that's worked in like risk management or system safety could have told the field. But I think it's because there was such a long time where these models were not working very well. We kind of got over indexed on, high predictive performance on like a static data test set, and being able to just demonstrate the fact that the model is able to do something. And I think now that we're getting models that are pretty accurate, our scope of understanding has sort of expanded, and we're realizing that, okay, the way that humans are interacting with these models really matters. The decisions and the way in which the models influence downstream decision making is really important. The way those decisions, don't factor into outcomes under certain circumstances. The environment and the context is really important, just as Steve was mentioning. So yeah, I definitely feel like we're now in this era where, because we're seeing actual implementations and we're seeing actual products, there's an awareness that you need to do much more than have a quote unquote accurate model in order to have, a downstream impact that leads to the kind of outcomes you want to see.
I'm going to say that successful AI implementation is a holistic process. I think that's the piece that we need to be thinking through. The other way I always look at it as it's a complex socio-technical dance that happens all the time. Like I think Steve touched upon many things, and Deb as well, mentioning the piece of how do I design, how I look for bias, how do I put things into practice so that it really drives the right outcomes. Change management, oh boy, it's a lot of effort from right from the beginning till the end, and certainly monitoring pieces. There is one piece which when I look at Kia, the first thing is regulatory compliance, another important piece that we always have to think through before we put something into practice. All these things, I charter all these things under the umbrella of, I would call that as operational governance. I think that's what we need to have in place, all the way from early stage selection of a problem, all the way through deploying and destruction of an AI solution so that it's not, when it's not working. I think thinking through the whole life cycle aspect of it, that falls under the operational governance for me. That's how I look at it.
And I would just add on to that, that something from working with lots of different clients across the sort of life sciences and healthcare spectrum, I think everybody's often surprised that, on the first foray into some sort of medical AI, with just how many different people, how many diverse people you need to have involved. You have a real cross-functional team, and that takes a lot of effort to get the right people in the right room, all communicating properly. And that's to, in your sort of design and build phase. And then there's another huge sort of resource lift and time investment in that communication, properly communicating out to all of your users and getting all of the feedback. So there's a real project management need around all of this to make sure that all the right stakeholders are consulted and you're getting all that input. And that is something that I think often, health systems aren't ready for it until you've gone through it for the first time. And you really need to have that overall view. And it's difficult from a practical perspective to do that well.
So we'll move on to a few individual questions where I can't emphasize enough, like the people in front of you today in the panel, everyone has such depths of expertise that we'll try to pull on some of those to surface it. So Deb, I'm going to turn to you next. We have an audience here of folks who help lead organizations in healthcare across North Texas. You were involved in some of the early work on bias in facial recognition systems, how to address that in industry. What advice do you have in healthcare for organizations today looking to more systematically address bias in algorithms that they're looking at for procurement or algorithms that they're already implemented?
Yeah, that's a great question. I was going to say, I think one of the sort of first, also to sort of describe my background in this space, I was on the sort of like building side of things. So I was on an applied machine learning team when I first discovered that, the data sets that we use for these models tend to not be very representative or misrepresent sort of certain underrepresented groups. And also, we had a culture in machine learning for a long time, that's only recently been changed, where we didn't really evaluate for performance in a way that was conscious or aware of the fact that there are various demographic subgroups and intersections of subgroups that are worth evaluating on. So I think starting there is honestly such a great place, where recognizing that, the populations that benefit from the hospitals are very diverse. And I know Alexandra was sort of mentioning or alluding to a little bit of the grassroots work that she's been engaged in on that front, but really understanding the communities that are being served, attempting to represent them in the evaluation process, and then ideally even incorporate them in the articulation of what the expectations of the system are before anything is even built, and the design of what these systems should be. I think sometimes people believe that, community participation should only really happen in the evaluation stage, and community representation is only really important when thinking about, defining subgroups for your evaluation test set or monitoring. But I think that there's sort of increasing awareness of the fact that these communities, need to be engaged at the design stage. They need to be engaged in terms of defining expectations for the system. And I actually think, the HAIP guide was a really great resource in terms of just mapping out all the opportunities and ways in which those considerations should be factored into how these systems are designed and developed and then deployed. And actually, I'm curious to hear Alexandra's thoughts on this as well, because I know that that's something you've been thinking about is on your end.
I gotta tell you, I'm a big fan of all of the folks in this team, but particularly Deb. What you talked about in terms of intersectionality, like, I've had to have this conversation with folks even as an individual, like how many intersectional identities particularly a person like me holds, and how as I approach, anything, it's like all these identities are very present for me. And we have very diverse constituents, we have very diverse stakeholders in every regard that, might have different intersectional identities. And the thing about predictive modeling and any model is that you're not going to get a perfect fit for every single diverse person, individual with the diverse contexts and, all the different factors. And so I tell everyone I'm a grassroots organizer living in Durham, North Carolina, that has a rich Black history. It was one of the Black Wall Streets in the nation, like one of very few Black Wall Streets. And there's a history of injustice of 147 completely plowing through the enterprise and the innovation and everything that was happening in terms of a community that was thriving. And so the highway, imagine a highway just ripped through all of that. And it's never been able to regain that identity. And so living in Durham means that, a grassroots organizer in Durham has to understand the history of Durham and understand the inequities in health and education, criminal justice, in terms of enterprise, business, all these different things. And it does affect health. Before, I remember there were so many projects with ArcGIS that were looking at asthma rates, and they happened to overlay data of like, were you living in subsidized housing? How does the air quality in the subsidized housing affect your ability or your outcomes, your health, like these health disparities when it comes to hypertension, diabetes, asthma. There's so many things that, with interpolating and using different data sets, especially with ArcGIS or using these different tools. Those were the conversations back then. Now through AI, and especially AI in healthcare, and some of the models, I think that the Parkland Center, they have this know thyself, framework where they actually bring in all these different like geographic things. And so it's very hard for one person to speak on, it's very hard for anybody to speak on all the identities they share. Because like, as I mentioned, I'm an very intersectional person with many identities that I can count with my fingers. And it's very hard to speak on all the needs of all the communities that have experienced marginalization in this country, or even in the city that I'm in, or even in this context of healthcare. So we have to do our best to just remain open and to give room for more people. So part of my work has also been to listen to others and to, try to figure out like, I cannot speak for every single experience, but I can speak to, the relationships that I have with other grassroots organizers, with other community representatives, with people who have also experienced harm in healthcare systems, who have offered their sacred stories of what has happened, including a Black man that I love dearly, he was an elder to me and a mentor, who told me that he has decided to switch, and I'm not going to say which healthcare system, from one system to another, because this system is completely lacking in terms of addressing the needs of Black men, especially as it relates to cancer diagnoses, especially as it relates to things that could have been prevented and medications he felt he shouldn't have been on. And he went to another healthcare system, and he felt like there was more cultural sensitivity, and there was more of an attuned desire to work from listening to him and really taking his his perspectives into account. And he feels much better. So it's nuanced. We have to make room for more people. And I'm glad to be a person here who's known of Mark and Suresh's work for a long time. I'd say like not super long, but to me, we went through a whole pandemic that feels like 1,000 years. So, and I remember Mark saying to me, he had a research project, and I was like, Mark, hold on. My community does not want to hear about research project right now. Like we really have people that are in need of information and the ability to collaborate with healthcare systems to address the disparities in terms of COVID rates. And he was very like eager to set up things and say, bring your community representatives, bring people in. I want to hear them. I want to talk to them. So I just give shout outs to people who do that, who make room for these perspectives that are very important and can actually determine outcomes for people. Thank you.
And I definitely think that's a recommendation we provide all organizations is solving these problems isn't just a technical task. So, okay, Keo and David, you're up next. You both are lawyers, which whenever I tell people that I love working with lawyers, there's an element of surprise. So everyone here, like, they're amazing. No reason to feel intimidated shooting us questions, shooting them questions directly that you have. So, a ton has changed in the regulatory landscape in the last 1 to 2 years since we started this project. We can't get into it in detail, but today, organizations looking to use AI, what do they need to be aware of in terms of legal and regulatory ecosystem as it is today?
I can kick it off. The first thing I guess that I think of would be, especially if you're partnering up with somebody to get this new tool that you're thinking of deploying in a clinical setting, would be thinking about that other partner and thinking about transparency. And I think that covers a lot of different things, but in particular, because we're talking about clinical use, maybe how about let's start with clinical validation of the tool that you're thinking about getting in. And I think that the partner, they need to be able to, and willing, they need to show understanding and testing or validation studies and give you enough detail to really understand it. And I think because we are coming from the legal perspective here, that seems to be a theme that is coming through from, sort of FDA action plans, from guidance, and we're starting to see it as well coming out of HHS with some finalized rules, really being able to communicate properly to the users what this thing actually does, what it is capable of. So I think that that's really important. And that will also allow you to know, what the testing population was, how well does it work on which populations? Do we have that diverse patient population? Is it generalizable to your particular use? So that information is really, really important. It's something that you need to know when you're sort of getting into bed with a partner, thinking about which tool. They should be really forthcoming. They should really understand their own tool. If they can't explain it to you, then how are you ever going to be able to explain it to the frontline workers that are using it and to patients? So that would be my initial reaction. David, do you have another take?
Yeah, and this is another place we could probably go in a lot of directions, but I'll just put it out there that I'm a really big fan of the FDA and the international standards that they utilize, and even just tying it back to that previous question we had about a model versus a solution. In my own experience working at the startup, we at one point had a model. It performed as well as a specialist, and we thought, wow, this is really great. Let's go sell it. And then we realized, oh, we got to go through this FDA thing. And the FDA immediately just said, like, that's not enough. We need to know that model is going to work in the intended setting where you're going to deploy it. We need to understand the ripple effect that it's going to have, the impact on the ecosystem. And from the time we had a model to the time we had an approved FDA-approved system was 4 years. We do that a lot faster now because this is like kind of in the early days. But that's the amount of rigor that they expect, and I think that's a really positive thing for healthcare. And then on the flip side, I'm really a fan of the FDA streamlining, accelerating, and making the processes that we have to go through more efficient. They've got a lot of new guidance documents, especially in the last two years or so, which are a lot more accommodating to software and AI and the ability to be more iterative. So balance those two things out, rigor, and then practicality and speed for which to achieve that rigor. And we're kind of moving in a good direction. So I'm a fan, but I want to maybe just target one specific thing, and I'm going to go to the chat and answer a question about agency, physician agency, and relate that back to the regulation. Melissa had a really good question about how do we retain agency of the physicians with clinical decision support software coming in. And again, I'll go back to in the last 2 years in particular, FDA has done a lot to define the boundaries of what rigor they would expect for clinical decision support solutions that are being deployed in healthcare. And one of the main things they consider is risk. So if there is a higher risk that solution will drive care or impact the physician's decision-making in a way that's biased, and not bias in the sense of automation bias, right? They're going to look at the result of that algorithm and make a decision of that algorithm. FDA has held a lot of guidance recently to say, we want to see those additional controls. We want to regulate that. So we can expect to ask those vendors, where are your validation studies? Where are your things? We can look at the FDA guidance and regulations, say, where are those things based off of this model? Whereas in FDA's risk-based approach, on the things that don't impact physician agency as much, where they're just more informational, maybe they provide a differential or more data about a patient for them to still use their own clinical judgment, there might be less expectation of regulatory rigor. So I'm kind of trying to answer two questions at once, but really say the FDA has done a much better job in the last 2 years of finding that line of when should we expect more rigor versus less. And I think from a physician patient perspective, if you see clinical decision support solutions starting to drive care, you should ask for that rigor. You should ask for the expectations that the FDA would have.
So we're going to go to the last section. I'm probably just going to do 2 questions, and then we're going to try to jump into the chat. And Alexandra, I want to prep you. I think if after the 2 questions, we can turn to Stephen Bull's comment, which I think gets into the rich history in Dallas specifically. So the next question is about capacity building. So here I want to turn to Steve and Suresh. So I am very biased in this assessment, but I have for a long time held PCCI in very high regard. They were one of the first really building these types of tools, implementing them. And then I've worked at DHI now for almost a decade. So these are 2 very well equipped leaders in the country in terms of health system innovation and implementation. Most of the organizations that we work with in Health AI Partnership are far behind where Duke and PCCI are. So the question to both of you is, organizations that are trying to build capacity quickly to harness AI, what do you recommend to them? Where should they start? What should they be doing?
Suresh, would you like to go first?
No, Stephen, happy to. I think you should start, and then I will chime in afterwards, if that's okay with you.
Well, I'll start by saying, Mark, your comments are incredibly humbling. So thank you for that. I would say there may be 3 things that really come to mind to directly answer your question. One is governance, and that is to be able to, you can't ignore this anymore. It's coming at you, it's coming at your clinical teams. It's something, as Suresh said, this is revolutionary, and it's not something that you should try to prevent entering your health system, is to try to create venues to be used appropriately within your health system. I think the governance structure, we have specific criteria and expertise for evaluating what problem you're trying to solve, evaluating the models or the solutions that are trying to solve the models, and then integrating within that the appropriate monitoring once you deploy. That's a core capability that you should stand up if you have not already today. I would say number 2 is expertise within your IT and analytical teams to be able not necessarily to build new models. If that's a path you're taking, absolutely you should, but to be able to take models and train them to your own population and data. That's an expertise that I think it's critical. And Suresh mentioned something very early on, that even that expertise is going to, with the new AI, is going to get democratized more and more. So, but that's a capability, because it's going to be extremely hard to take a vendor model or somebody else's model, say, I'm just going to adopt it. Chances are really good you're going to have to train that model to your own patient population for it to represent the nuances of who you're treating and get to that personalization. And the last and third one is to collaborate. Find others, call it like me, that have similar patient populations, and create a coalition where not only can you learn, but leverage the different things that they're doing. Involve the community in this as well, because we're still going to need to talk to people. Probably, if anything, becomes even more important than ever, and that's both on the community side as well as the clinical side as well. So I would say those are three things that I would do and start doing today, or if you're doing some, I'll round those up with some of the other pieces.
Steve, I would say we are impressed by what you have done, because you are certainly, right from the beginning, we've been tracking you for a while in terms of data science, use of data science to drive innovation in many ways and impact care. Certainly very, very impressed with the work that you and your team has done. And certainly I want to say that Mark is biased, and so am I in many ways, because Mark is certainly, maybe I should say that building AI capability is a journey, and I think it continues on. And Mark has been, the whole DHI team in here has been a part of our journey, helping develop those capabilities. And I would put those in terms of into four core buckets as a starting point, so that you can expand from there. The first one for me is always, how do we really prioritize and focus, right? Looking at very specific goals or identify areas where AI can significantly improve patient care or efficiency. If you're a health system leader, that's what you're looking at, or drive research. I think having that very narrow focus is going to be incredibly important. Like starting small and then scaling is an important aspect of it. And then the way we had done it, where we have been successful, is to leverage our existing infrastructure. Don't try to create something new and learn. It's just going to postpone the ability to create the ROI and the value for our patients. So leverage the existing IT infrastructure. And certainly, I think Steve mentioned this, governance is an important aspect. We need a team. I think create a small internal AI team. And I think Steve also mentioned about fostering collaborations. We will not be able to collaborate and do things without multiple experts at the table. And I think I'm going to go back to Deb and Alexandra and say that I think engaging the community right up front while you're forming this is going to be very, very impactful in terms of creating value for the community where we all live in and serve. I think that's an important aspect. So, and then investing in training is an important piece, education, workforce development, and educating how people should use AI responsibly. I think that's another area that we should all be doing that. That's all about the team aspects of it. And data and infrastructure, I would certainly say, is an important piece. High quality data, I think there were a lot of questions related to that. And certainly data security and privacy has to be first and foremost consideration as you develop that data and data infrastructure that you want to have in place for deployment. And fourth is, I would say, partnership and adoption. I'm saying adoption because Steve touched upon it in multiple times as well, which is develop a change management strategy. You need that in place before we put any of the AI into practice. And then certainly having a monitoring and evaluation plan is an important aspect of it as a part of the adoption and implementation pieces.
So it's a long journey that we are trying to help folks through in Health AI Partnership. I know that we are almost at time, so I want to give Alexandra the opportunity and anyone else to speak to Stephen Bull's question.
I thank you so much, Stephen Bull, for this comment. I mean, it just brought up so much for me in terms of the similarities of dynamics that happen across the country in ways that we continue to see similar patterns in terms of disenfranchisement, sometimes by geographic barriers. But in this case, it's a river, and I have a bias that I love rivers, and it just gives me such hope when I think about the work around rivers and work that I have seen locally here in North Carolina, particularly in Sampson County, which is about an hour and a half away from where I live in Durham, and where Mark and Suresh and some of the Duke folks live and work. But I can tell you that in Sampson County, the Coharie River has been like a landmark for a long time for Indigenous communities, especially the Coharie tribe. And that was at one point restricted because it was privatized. And there was such a benefit of community members grappling with inequities in health, education, along a cleanup of a river. And when I just even looked up the Trinity River, I believe it's the Trinity River in Texas, in Dallas, Texas, that I see it's very heavily contaminated. There's definitely a lot of concerns in terms of equity, in terms of racial equity, particularly. But what gives me promise is hearing that there are some ways that the city has like a racial equity plan. And anytime you talk about racial equity plans, you have to bring in historical context. You have to bring in like who has been trying to approach this problem. And that's, I think, the opening for healthcare systems to work with community leaders, to have maybe bring in some of the university side, like university researchers. And for example, for the Coharie River, the example that I'm giving, the UNC system, actually the University of North Carolina system actually has the American Indian Center that actually partnered and did some grant writing around addressing some of the impact of the Coharie River that was, polluted, it was dirty, it was inaccessible to communities, and also how to develop this framework that is called Healthy Native North Carolinians. Healthy Native North Carolinians was focusing primarily on the health of American Indians throughout the state of North Carolina. And I think when it comes to what you were expressing about that river just blocking off in a way access to the healthcare system, and I don't know that the closest one there is Baylor University Medical Center. It says that also Methodist Dallas Medical Center is also nearby. I think that there has to be some work in terms of identifying those folks, whether they're grassroots or community leaders who have been approaching the inequities around health disparities, and for them to have a way in. And maybe with the city plan that they have, like the city council, I'm somebody who's in the school board. I've been on the Human Relations Commission, so I've been a commissioner with the Human Relations Commission. And I think that there's opportunities if there's a Human Relations Commission in that area to kind of bring in. That's how Mark and I connected, actually. Funny enough, circling back to this, that it was actually through the Human Relations Commission and the work that I was doing there that I heard about Mark's work, and we established a connection. So there's a way to kind of bring this to the city as well, and continue to like build support for health equity, which integrates the perspectives of community leaders, grassroots, into the plan to make things better. But this offering that you gave today is just so rich, and I think I can go in so many different directions. But I think ultimately, the geography is a very important part of health access. It's always been, from the history of the United States. Geography has been a very important factor in all this, and I thank you for offering that to us.
So Teresa, I know you came off camera. Thank you for giving us the opportunity. And Alethea posted, we are actively looking to engage more organizations, and this group of people, we're thrilled to be able to continue to work with them to support health systems.
Well, I just want to say thank you to the whole group. Wow, what a learning experience. And, it brought up a lot of things for us to think about. And I appreciate inviting us, to participate. We have, Steve can probably help me with this. I mean, we, in our organization alone, we have like 114 hospitals participating just here in the DFW area. So there's a lot of opportunity for us And what's really unique in this area is the hospitals here in the North Texas region really collaborate together through this organization. Steve's shaking his head yes, and because he's helped, in a lot of that. We have a good relationship with PCCI, and they've helped us with some things that we've been doing for the community. So, hopefully maybe there's an opportunity for us as a collaborative here with all the hospitals to partner with Duke and maybe participate in some way. So that would be really great. And I appreciate y'all taking the time, all of you, to be a part of this conference. And great job. And I see Jen posted, Jen Myth, Steve's other half. Thank you to the whole panel for your thought leadership in the space and for engaging with our participants today. So she appreciates y'all participating. And I see also Shareth saying thank you for the opportunity. So great job. We appreciate all of you, and y'all are welcome to stay for the rest of the day or attend tomorrow. But thank you so much, Mark.
Thank you.
Thank you all.